Hello students, welcome to this Anaesthesia NEET-PG 2024 recall session. I am Dr. Ramakrishna Chaitanya, your Anaesthesia faculty. So, the much awaited examination of this year, NEET-PG 2024 has been finally concluded, right? So, with a lot of confusions, chaos, movements, lot of, you might have gone through a lot of things which normally a student might have encountered all these things during their preparation phase. First of all, congratulations to all of you because you have gone through this all successfully. You have written this examination. By this time, your mind might have been cleared, right? What you have written, what you have not written, where you have went into the mistake, and all these points you might have getting into your mind. Some people are okay. No people, not only for you, most of the students, they are not quite happy or they are not quite sad. Like most of the students, some people, they know definitely that, okay, I'll get something. Some people are in a confused situation that I am whether to continue or whether to not to continue or how to prepare and all these things. So for a time being, just keep all these thoughts into a full stop for it. And, because there is no point right now. So if you are very sure that you are getting a clinical seat, which I don't think most of the students will agree to this, but yeah, some students felt that I have done it better. So those students can relax. But the students who are thinking that I can do better or there is a scope for me to improve. So these are the students, they should always continue to the preparation because we don't know when the results are going to come. And if you get a seat, that will be an added advantage. If you don't get a seat, it will not act like a setback to you. So you will be continuing your preparation. So with this, what I will do is, for the students who are watching this session, most of the time they are in this confused situation. So for me, if you are in a confused situation, my path is very simple and straightforward, that you continue your preparation. So keeping all this in mind, let us start our anesthesia recall session, right? So this year we had some good questions in anesthesia and most of the students, they are able to answer this. Particularly, I inquired a lot of students and I found out that the students who have watched all the videos, those who have made the notes or read the notes properly, they could easily answer the questions. I generally don't like to say that everything came from my notes. But yes, obviously, a lot of information what we have provided in the videos and the notes, they have been covered in the examination, right? Apart from one or two areas where you require critical thinking, right? So I'll tell you what are those areas. So the main purpose of this recall session is to recall the questions. That's a point one. But the second thing is how the pattern of changing the questions. Because you might be knowing most of the students have said the session 2 is slightly complicated. So you should take up this session in such a way that you have to recall all the questions. The second thing is those who are preparing, they have to change their mindset. They have to change their way of preparation for this entrance examination. So with this small introduction, shall we jump and see what questions came in this NEET-PG 2024 session? Right. So the first question that was being asked in your entrance examination is, okay, let us see this question. This is a very standard question. A patient is on mechanical ventilation for surgery in prone position, right? So they are specifically saying in prone position and is maintained on PEEP. Is maintained on PEEP. What is the significance for the same? So over the same means, I think they are asking for the significance of the PEEP, right? What do you mean by PEEP? So PEEP means positive end expiratory pressure. Positive end expiratory pressure. So we all know this. So every time when I took the classes in the Marrow videos regarding the chapter of mechanical ventilation, I said inspiration is an active process where your alveoli will be enlarged. But expiration, what happens? Expiration is a passive process where due to the elastic recoil of your lungs, the lungs walls will come closer to each other. But so this happens something like this in your alveoli. So this is the alveoli. The alveoli size will increase when you are inspiring, right? And the alveoli size will decrease when you are not inspiring. Due to the elastic recoil force, the alveoli try to collapse. But normally what happens is, in your lungs, they don't collapse completely. They are not going to collapse completely. Why? Because in your lungs, there is something called as a surfactant. This surfactant, it prevents the collapse of the alveoli. But in certain disease conditions, for example, ARDS. Why I am quoting this example of ARDS? Because in the question they have mentioned it as a prone position, right? That means prone position is generally used in ARDS, and typically we use a lot of prone position ventilations during our COVID sessions. Okay, so in ARDS patients, we keep the patients in prone position, and that is the reason why they have asked this question. In ARDS, what will happen is the lungs compliance is affected so much that this lung walls, they tend to collapse. And once it collapses, what will happen? See here, no force in this world can open up the lungs. So if you want to improve the oxygenation of the patient, make sure that the alveoli are kept open. Normally, it is kept open due to surfactant. But in some disease process, this surfactant might be affected, or due to some disease process, the alveoli tend to collapse. The moment they collapse, the oxygenation will be affected. So in order to prevent this, we generally use, when a patient is on mechanical ventilator, we generally use PEEP. The name itself is saying positive end expiratory pressure. That means this expiratory pressure at the time of exhalation, when the alveoli are coming closer to each other, it will give some positive pressure. The moment they are putting positive pressure in this alveoli, the alveoli will not collapse. And once the alveoli are not collapsing, it will try to improve the oxygenation of the patient, right? So this is the concept of the PEEP, which I have discussed in the video session. Now let us look at the options so that you will easily understand, right? So what is the purpose of the PEEP? In nutshell, what they are asking is, what is the purpose of the PEEP? Decreases the inspiratory pressure? No. It will not decrease the inspiratory pressure. I am saying I am adding the inspiratory pressure, right? So at the time of expiration, we are adding the pressure. So it is not somewhere. The name itself is saying PEEP, positive end expiratory pressure. And they are saying inspiratory pressure. So this might not be a correct answer, right? So it prevents the alveoli collapse and atelectasis of the lungs. Yes, this is the correct answer. But let us see the C option also. Increases venous return and thus maintains the cardiac output. No. Whenever there is a positive intrathoracic pressure, normally I said you in that video that when we are breathing negative pressure, there is a siphoning effect, right? Because of the negative intrathoracic pressure, the blood in the great vessels will be pulled and dropped to your heart. The moment this negative pressure is converted into positive pressure, what will happen is the preload to your heart is decreased. That means the venous return will be decreased. What is the correct statement? Venous return is decreased. If the venous return is decreased, that means preload is decreased. That means afterload is also decreased. So this is called as Frank-Starling's law. So this is absolutely wrong statement. Increase in the venous return. Reduces carbon dioxide in the alveoli. Sir, how is carbon dioxide affecting? We all know in our physiology, it has been taught carbon dioxide is a gas which has got highest diffusion capacity than oxygen. The moment the alveoli opens, the first gas that will be escaping from your lungs is carbon dioxide only from the lung. But here, this carbon dioxide in the alveoli, it will not stay back. When you open up the alveoli, it will not stay back in that alveoli. So it will try to move out of the alveoli, right? But the real problem in ARDS patient is not carbon dioxide problem, because carbon dioxide problem is typically seen, it is not exhaled in a patient with asthma or obstructive lung diseases. In obstructive lung diseases only, the exhalation of carbon dioxide will be a problem. In typically a prone position or ARDS patient, the main problem is oxygenation. So when we are keeping a PEEP in the patient, it is no way affecting the carbon dioxide. PEEP will always improve the oxygenation, because for carbon dioxide, it doesn't require anything. The moment there is a slightest opening also, the carbon dioxide will flush out. So this is also not a right option. So what is the correct answer in this? So it prevents alveoli collapse and atelectasis of the lung. The same question, more or less like a same question, has been asked multiple times in the previous year INI-SET question papers. In the previous INI-SET question papers, this question has been asked about the PEEP and its significance. Okay, So this is the first question that has been asked in your entrance examination. Shall we see the second question? Right. What is the second question? A patient presented with the features of acute exacerbations of COPD. COPD means obstructive lung diseases and required mechanical ventilation. Right? Mechanical ventilation. There was a saturation drop consistently, and on auscultation, vesicular breath sounds are heard on left side. That means on the left side of the heart, chest wall, you can hear a normal kind of breath sounds. The chest radiography was taken and it shows the following finding. What is the expected auscultatory findings on right side? Now let us see the chest X-ray. See the chest X-ray. What is there? This is a classic chest X-ray. On the right side, you can see that there is a pneumothorax. Very good. That is the reason why. Now see here, there are so many points which are pointing out towards the pneumothorax. One is obstructive lung diseases. The chest wall has been the lung wall, the elasticity of the lungs has been decreased. So when you ventilate the patient with the obstructive lung diseases, there might be chances of development of pneumothorax, right? So that is one thing. The second clue in that question is SpO2 is not maintaining. They are saying very clearly, SpO2 is not maintaining in the patient. Consistently, it is reducing, and you can hear normal breath sounds on the left side. You can see nice markings of the on the chest X-ray also you can see. So right side, it is a very classic picture of pneumothorax, right? Now, how do you identify pneumothorax? This question, you will not believe, every year in one form or other form, they ask a question mandatorily on pneumothorax. Okay, right. How do you identify a case of pneumothorax is, let me tell you, how do you identify the case of pneumothorax is, on the affected side of pneumothorax, on the affected side, there is no air entry. There is no air entry, right? Or decreased breath sounds. Decreased breath sounds. Or if you remember your clinical postings, you might have seen the chest wall movement is also reduced. Chest wall movement is also reduced, right? The very classical feature is when you percuss on the chest wall, you can hear hyper resonant note. Hyper resonant note on percussion. On percussion, right? So, because there is accumulation, we all know pneumothorax means there is accumulation of the air, right? So, let us see what has been given in the options. What is the option? The first one, you can hear the bronchial breath sounds. Just now I said you cannot hear any breath sounds because this is a case of pneumothorax. So, this is the wrong option. Absent breath sounds. Yes, this is the right side because on auscultation, you cannot hear the breath sounds on the right side. Right, let us see the next option also. Increased vesicular breath sounds. No. Obviously, this is not an option, right? Then coming to it, vocal fremitance or resonance. We don't know what has been given in the option. Vocal fremitance and resonance is increased. On auscultation, vocal fremitance is also decreased. This is a classic presentation of pneumothorax. And in pneumothorax, on the affected side, there is definitely decreased breath sound. That is the reason why in our practice, whenever we see a case of pneumothorax, what we do is, first we try to auscultate and see. When we are suspecting pneumothorax, first we try to auscultate and see. So, if we are not hearing the breath sounds, then we should be very, very careful. So, one side breath sounds are not heard, and on percussion, if you are seeing hyperresonant note, immediately we will get a chest X-ray and try to identify whether there is pneumothorax is there or not, right? If there is a pneumothorax, positive pressure ventilation will worsen the situation. That is the reason why the saturation is not maintaining. Even though the patient is on ventilator, the saturation is not maintaining because of this reason. So what is the correct answer out of all the options? Absent breath sounds on the right side. Now some students might have got confused, but see here, resonance is increased. But resonance is increased where? On percussion. So read the question properly. So they have asked on the auscultatory findings. So auscultatory findings, definitely breath sounds will not be heard on the affected side. This is the classic question on the pneumothorax. So please, those who are preparing again, make sure you identify the chest X-ray, because the whole point in this chest X-ray is identification of pneumothorax. Once you identify, the job is in front of you, right? Shall we see the third question? Third question that has been asked is, in the following condition as shown in the radiograph, I don't know, lot of questions have been mixed with radiology people, right? This is the third question. So which of the following procedure would be difficult to perform? So what is there in that radiograph? As per students recall, can you see here, this is an X-ray of neck, right? The chest walls are not clearly seen, but what we are interested here is, I am interested to see that this is a classic finding that the air shadow in the neck means this is trachea, right? The air shadow is pulled to one side. That means there is some amount of tracheal deviation. Why there is tracheal deviation? We don't know, because we are getting only half frame of the picture. We don't know the exact reason why there is tracheal deviation. But here the classical picture, what they are showing is trachea is deviated to the right side. To my right side, it is deviated. So which of the following procedure will be difficult to be performed? Insertion of a nasogastric tube. How is nasogastric tube will be inserted? No, it is not a difficult procedure, because when we are inserting, one of the easiest procedure where most of the students might have done during their internship is putting a NG tube or a Rice tube. If the trachea is deviated or not, NG tube is not going to affect, because NG tube goes behind it. So nasogastric tube insertion will not be that much problem. LMA insertion, LMA, laryngeal mask airway, it is a supraglottic airway. I am not going down. Supraglottic. The name itself is saying supraglottic. One means that is sitting above the glottis. It is no way concerned to difficulty in passing the supraglottic airway. Supraglottic airways are difficult to pass when the mouth opening is not adequate. So this is also not a correct answer. Okay, this is also not a correct answer. Tracheostomy. Yes, there can be chances of tracheostomy difficulty. Why? Because generally in tracheostomy, we take a midline incision. You might have heard during your ENT sessions also. So this is a combination of radiology, ENT and anesthesia. Why anesthesia? Because they have said laryngeal mask insertion and etc. etc. So that's the reason why I am telling this question, right? So in tracheostomy, you might have noticed that they do a midline incision. They will separate these trap muscles, right? And the moment you separate these trap muscles, obviously you will see this tracheal rings. Now, if the trachea is deviated to one side, obviously the the performing a procedure like tracheostomy will become slightly difficult. So this might be the correct answer. Then coming to indirect laryngoscopy. It's not even direct laryngoscopy. They are saying indirect laryngoscopy. Again in ENT point. In indirect laryngoscopy, you just put it something like this and see the vocal cords, right? This is all happening below the vocal cords. So this is also not a right answer. So what is the correct answer in this question? The correct answer is tracheostomy, right? So don't get confused. Most of the questions in the examination hall, if you think normally also, you can able to answer. This is the whole tea of the preparation. The whole tea is not to mug up. When you are writing your examination, make sure you train your eyes and mind to read the question. Think like a normal person. This is, I know, telling is very easy. But definitely, if you think like a normal student, most of the questions can be easily answered in the examination hall, right? So this is the third question that has been asked. Now, now let us see the next question, what they have asked in your entrance examination. Identify the instrument that is given in the picture. So this is a classic picture which I have shown in the videos. Even in the revision session, even in the notes also, it has been given. Many students have recalled it. The correct answer is a nasopharyngeal airway device, right? This is the correct answer. Oropharyngeal airway device, it is called as Goodell's airway. Goodell's airway. What is the purpose of Goodell's airway? I said you many times, Goodell's airway prevents the tongue fall back. Okay, so uncuffed endotracheal tube. Some students might get confused with uncuffed endotracheal tubes, but most of the students, those who have attended the clinical postings, they are not in confusion. Why? Because uncuffed endotracheal tubes will be slightly lengthier and most of the times they are very narrow. It will not be so thick like this, right? And you can see a very good plastic connector there. Very good plastic connector. You might have seen the endotracheal tubes, right? So the same thing. So uncuffed endotracheal tube might not be a correct answer because most of the students, they called it as nasopharyngeal airway only. Ovosapien airway. This is a typical type of airway, which again it is oropharyngeal airway, which is not used routinely in our clinical practice. The answer is straightforward in you. That is nasopharyngeal airway. This has also been discussed in the revision sessions and the video sessions. So this is also a repeat question for you, right? Now, next question. A patient was given local anesthetic before IV cannulation. Before IV cannulation, they are putting some local anesthetic. Which among the following statement is true? Now, see the picture. What is this? I told you, many times I told you, this is a classic picture of Yamla cream. Yamla. Yamla means eutectic mixture. Eutectic mixture of lignocaine plus prilocaine. Generally, as a pediatric anesthetist, I see lot of patients, or I use lot of patients with Yamla cream. What we do, one of my biggest nightmare, I said the same wordings in the video session also. One of my biggest nightmare in the hospital when I am working is if someone calls me asking me to put a cannula in the children. Why? Because children, they are the toughest people for me. Because putting a cannula, that's a small procedure. But what happens is, by the time they call the anesthetist, every person in the hospital, they might have tried putting the cannula, right? The second thing is, veins are obviously not visible. Third thing is, children are inherently not cooperative. There will be lot of emotional aspects of parents where they will be crying. They don't want the children to be crying, right? So they will be on a very stressful situation. And fourth thing is, I require lot of manpower in the form of 4 or 5 people to put a small simple IV cannula, right? I don't want to enter into that vicious cycle. So what we do is, whenever we see a child for IV cannulation, we take a sticker of Chota Bheem or He-Man, and behind that sticker, we apply this Yamla cream. What is this Yamla cream means? It's a eutectic mixture. What do you mean by eutectic? It's a mixture of 2 local anesthetics. So that the resultant material, when we combine the 2 local anesthetic, the resultant substance melting point is low. If the melting point is low, it can get absorbed into your skin. Absorbed into skin, and the moment it gets absorbed into the skin, local anesthetic, so that area will become numb. So we take that Chota Bheem sticker, He-Man sticker. Behind that sticker, we put this cream, we put it on the hand and allow them to play. After 30 to 45 minutes, again I am specifically saying 30 to 45 minutes, what we will do is, we will call the child. The child will come to us because you have given one sticker, right? The moment the child comes, we remove that sticker. Now here comes the experience. I said the same thing in the video session also. I don't throw it in dustbin. Why? If I throw it in dustbin, the child will cry because the child is emotionally attached to that. So I will remove that sticker and put it on this hand. By the time the child is looking at this sticker, I will put a cannula without causing pain. And once I put the cannula, I will remove the sticker, I will close this IV cannula and I will give the baby to that. So in a smiling situation, we can do this procedure, right? So let us see the options. What we have discussed, that what only I said you, right? It's a made up of lignocaine and ropivacaine. No, Yamla cream. Same here, you can see here, this is a sticker, right? So actually in this sticker, they are putting like a tegaderm. This is called as tegaderm. That's plastic sticker. But what we do in pediatric hospitals is we take this Chota Bheem sticker, something like that, right? So it's a eutectic mixture. Yes, this is the right answer. Eutectic mixture. Methemoglobinemia is a side effect. Now this is slightly tricky, right? So prilocaine, when it crosses the overdose, prilocaine, when it goes into an overdose, the side effect of prilocaine is methemoglobinemia. The side effect of prilocaine is methemoglobinemia. There are some reports where the children have developed methemoglobinemia because, I said some amount of sticker, right? So some amount of cream I will take and put it behind the sticker and put it on the hand. There are some case reports where due to Yamla cream, there is a chance of development of methemoglobinemia. So methemoglobinemia is also correct statement. Generally, what we use in our practice is we mix 2.5% lignocaine and 2.5% prilocaine. Okay, so methemoglobinemia, unless and otherwise, I don't know whether the question is given a patient, a child, or an adult, something like that, methemoglobinemia is a side effect. Yes, that is for sure. It is seen more commonly in neonates because there are some reports of neonates because, an adult will not get methemoglobinemia. That much sticker will not use. And even in children also, I am not very sure. Yes, there are no reports. But neonates, there is a chance that they will develop methemoglobinemia. So both these options are looking right only. 1 gram. Let us see the fourth option because, this is a recall session. Might be they asked something else. 1 gram of 0.5% cream contain 50 milligram of lignocaine. 1 gram of 0.5% cream contains 50 milligrams of lignocaine. 2.5% is generally available. That means what will happen is generally in 2.5% there will be 25 milligrams. 2.5% there will be 25 milligrams. But in 0.5%, I don't think 50 is the right answer. Right? 50, that too in the cream. 2.5% will contain 25 milligram. If they said 5%, maybe 50 milligram might be correct. I am not very sure, but because this is a recall session, I don't think 0.5% of the cream contains 50 milligram is a right answer. Because generally we use 2.5% and we take it in a very significant quantity, 1 to 2 grams of this, and we try to put it. So either it should be a 5% cream, yes, because in market 5% creams are also available, not only 2.5%. As per textbook, 2.5% should be used, but in market 5% creams are also used. But for 0.5% containing 50 milligram, I am not very sure. 1 gram, again, it's not even 1 ml because 1 ml means might be, because 1 ml of lignocaine, generally what we do is, I'll write it here, you will understand this lignocaine is slightly tricky. Generally what we do is, we have 1 ml of lignocaine. In our clinical practice, what we use is 1 ml of lignocaine, which is 2%, which contains 21 milligrams. Okay, so if I make it 1%, 1 ml will contain 10 milligram, obvious. Right? If I make it 0.5%, it will contain 5 milligram. Okay, so this is 1 ml of liquid lignocaine. 1 ml of liquid lignocaine. But in EMLA cream, it is not a liquid. So it is always, cream means some substance. We will measure in milligrams only, right? So how much is the percentage availability? It is 2.5% as per textbook. But there are chances that they might keep 5% also, right? 1 gram of 2.5% will produce 25 milligram. Okay, 25 milligram. So might be this fourth option is also not a right answer for this. Fourth option is also not a right option. Which is the true statement. If you want me to, I don't know exactly what question has been asked, but if they give you 2 options, unless the national board gives us a correct answer, I cannot tell what is the right answer for you. But if you want me to pick, I'll pick eutectic mixture only because their methemoglobinemia is a side effect, but slightly rarer side effect. I don't say this is wrong answer because I don't know which one they have asked, whether this option has been asked or not, I don't know. This is slightly controversial. I don't know why this kind of questions will be asked. Whether if it is a false statement also, there are 2 false statements. There are 2 false statements according to me. And eutectic mixture, methemoglobinemia side effect, if at all any other options is given, just let me know. Or if at all they said false statement or something else, if the question is not framed correctly also. So please try to understand the concept. That is very, very important. Okay, right? So slightly confusing question. We don't know the exact answer, but I will choose eutectic. Suppose if the same question is given, why I choose eutectic means that is definitive. Methemoglobinemia is also correct. I am not saying that is wrong. Methemoglobinemia, there are reports. It is seen in neonates. If they have specifically mentioned a child or an adult, might be that's a rare side effect. So I don't think that will be the right answer, right? So just look at the question, or if you can recollect it, please let us know. We will correct and I'll tell you the right answer also. Okay. So this is the next question that has been asked in the session 1, right? Now let us see the next question. Again, this is a question which I got from the students, which I didn't get the options correctly, and most of the students, they couldn't recall it properly also. Okay, let us see the question. The purpose is to recall the question and reflect what we have written it. If you can recall it correctly, let me know. I will also try to answer it. An 80-year-old person, male, is suffering from COVID. Oxygen saturation is 84%. Nasal cannula is delivering oxygen at the rate of 4 liters per minute. That much only I recalled that question from the students. If any student recall the full question, please let me know. But quickly, I want to tell this point. Every year, one question about the oxygen delivery devices. Oxygen delivery devices. Even in the recent INISET which happened in the May, there was one question. Let me quickly recapitulate for you because we don't get the options. Oxygen delivery devices, there are two types. One is a high flow, fixed performance. The second one is low flow, variable performance. High flow fixed performance example is Venturi mask. Venturi mask is a fixed performance device. That means it will deliver the precise amount of oxygen. So it is generally used in COPD patients. Low flow variable performance, the first example is nasal cannula, where we use a flow rate of 1 to 6 liters per minute. And each 1 liter increases FiO2 by 4%. 4%. So totally how much FiO2 it will increase? Total increase in FiO2 is 44% or 45%. Sir, how it became 44 or 45, sir? You said 6 liters, 1 to 6 liters. Each liter will increase 4%. How it became 44? Sir, we know mathematics very strongly. 6 4s are 24. So it should increase by 24 only. But this was the tricky question that was asked in recent INI. Said 24% definitely it is increasing. But it is also, you are forgetting the fact that you are taking atmospheric oxygen also. That means 24% plus 21%. How much it will be? 44 to 45%. So might be this question has been asked because this was asked in the recent INI set. So if you are receiving, suppose if the question has asked something like this, if you are receiving, let us see the question. Okay, before going to that question, quickly I'll tell you what are the other options of low flow variable performance. The second option is simple oxygen mask, which can deliver up to 6 to 10 liters of oxygen, and the FiO2 it can increase up to 60 to 65%. The third option is NRBM, non-rebreathing mask, where you have to keep the flow rates around 10 to 15 liters per minute, and the FiO2 it can increase up to 80 to 85%. Some books says 88, 90 also, that's fine, but 80 to 85 is the correct one. So let us go back to our question. The question that has been asked in your examination is, he is suffering from COVID and the oxygen saturation is 84% and we are giving nasal prongs through nasal cannula or nasal prongs 4 liters. So how much FiO2 it will increase? I am just speculating this question. How much FiO2 it will increase? So 4 liters, 4 into 4, 16 plus 21. So it comes to around 37% FiO2. The patient might be receiving 37% FiO2, if I am not wrong. So I am just speculating. Or it is a low flow oxygen device, low flow oxygen delivery device. Okay. So this might be the question that can be asked. I don't recollect because this is a recall session. Again, the students have given this much only. If at all you recollect the correct question, please let me know. I will try to incorporate in a session or in the theory form, something like that, I will tell you. Okay. So let us see the next question. What is the next question that has been asked? Which of the following agents can be used for reversal of vecuronium when renal function tests are normal? Okay. Again, this is slightly tricky. Vecuronium, any non-depolarizing muscle relaxant, we reverse with the help of neostigmine. Neostigmine. I have said in the class, any non-depolarizing muscle relaxant, they have been using neostigmine in our daily practice. In my 15 years of my practice of anesthesia, I use daily neostigmine only. Along with neostigmine, we add glycopyrrolate or atropine. Why we are adding glycopyrrolate or atropine means neostigmine is acetylcholine esterase inhibitor. So there will be increased levels of acetylcholine. So whenever there is increased levels of acetylcholine, muscarinic symptoms are there. There are chances of bradycardia and all these things can occur. To counter this muscarinic symptoms, we are adding atropine or glycopyrrolate. Okay, but in 2017 or 18, not in our country, there came a new reversal agent that is called Sugamadex. Okay, the Sugamadex was specifically introduced to rocuronium, and I have said it in the class. Rocuronium is the combination of Sugamadex and rocuronium is a wonderful combination. It will reverse the effect of NDMR very quickly. Like a switch, you can reverse the effect of NDMR, right? Now this was given, but what they have found out is this Sugamadex is used mainly for rocuronium, but there are some, because rocuronium, these non-depolarizing muscle relaxants, they are categorized into two categories. One is steroidal compounds and benzyl isoquinoline. All these points I have told in the video session. Okay, benzyl isoquinoline, right? This Sugamadex, again later they found out this is also useful for steroidal compounds like vecuronium also. So what does this Sugamadex, ideally what it do is, Sugamadex, it binds to the NDMR molecule and it excretes the substance, whatever it is bounded, like a ball, it will go and bind and it will excrete through the urine route. That's it. So if the urine is, if you are able to pass urine normally, what Sugamadex will do, it will bind to this steroidal non-depolarizing muscle relaxants and it will excrete through urine. So what I told in the class is, because most of the times, even in the recent INI set also used, they asked this question, rocuronium plus Sugamadex is a combination that is used, which has a quick recovery and it is preferred in daycare surgery. But it doesn't mean that only rocuronium. They have proven that it can also be used in vecuronium. In the video recalls, in the video session, main video session, I said the pharmacology of rocuronium is entirely similar to vecuronium. Everything is same. I used the same word. Everything is same except that vecuronium is a cardiostable type. It is used for cardiac surgeries, etc., etc. Rocuronium, it has got specifically Sugamadex, but it can also be used for vecuronium. Okay. So, what is the correct answer? Physostigmine. No, physostigmine is never used because physostigmine, it causes blood-brain barrier. Generally, physostigmine we use, if you remember your pharmacology, it is used for central anticholinergic effects. It has got central anticholinergic effect. We don't use physostigmine. Rivastigmine, pyridostigmine, we don't use it clinically for the reversal. Because all these stigmines, neostigmine, physostigmine, they are, only one compound that is used, that is only neostigmine. Physostigmine, pyridostigmine, rivastigmine, it is not used. So, Sugamadex can be considered. Succinylcholine is no way correct answer. So, what is the correct answer? Out of all the options, Sugamadex. This is slightly tricky, right? So, generally, Sugamadex is combination with rocuronium, but it doesn't mean that it is only used exclusively for rocuronium. It can also be used for steroidal compound like vecuronium also. So, the correct answer is Sugamadex. Physostigmine, rivastigmine are not preferred. And these agents, Sugamadex is a wonderful agent. It can excrete through the renal agent. So, renal function is normal means you choose the answer directly as a Sugamadex. Okay. This combination is introduced. Sugamadex is introduced. Why I was expecting this question because this was introduced in our Indian market last year only. In the month of 2023, March or April, May, something, this drug is introduced into the Indian market. Okay. So, this is the next question, right? So, what is the next question that has been asked? A 3-year-old child is presented with drowsy or refusal to feed and on examination, the child was stupor. ECG was shown below. Right. ECG was shown below. What is the next best step? Okay, this, yeah, fine. This is a 3-year-old kid, maybe a pediatric, but the answer doesn't make much difference, right? Whether it is an adult or pediatric, I have made a separate module of basic life support and advanced cardiac life support in our regular videos, right? And this ECG is a classic of VT. It is a classic of VT, right? And the patient is drowsy, refusal to feed, etc., etc. So what is the correct answer? So ventricular tachycardia, and the patient is having ventricular tachycardia. It is a pulseless rhythm. So what you have to do is stupor. Child was stupor and ECG is showing like this. VT is coming. So immediately it is a shockable rhythm. Many times it has been told in the videos that there are 2 types of rhythms are there. The first one is the rhythms in ALS, ACLS. I taught about ACLS. This is a pediatric case, I know, but it doesn't change much. Pediatric or adult, if the rhythms are there, they are classified into 2 categories. One is non-shockable. The second one is shockable. Non-shockable and shockable. Non-shockable, whether it is pediatric or adult, it is asystole. The second one is PEA, pulseless electrical activity, where asystole means straight line, pulseless electrical activity means some activity will be seen. Whereas shockable rhythms are 2. One is VF, ventricular fibrillation, where you will see the waves like this. The second one is PVT, pulseless ventricular tachycardia or polymorphic ventricular tachycardia. Both are this. So where you will see this kind of waveforms like this. So ventricular tachycardia. So in ventricular tachycardia, it is a shockable rhythm. So immediately give defibrillation. The moment the defibrillation is given, you should not say yes, yes, yes. I used the same word in the video. Immediately continue the CPR. The moment you give the shock to that baby, you have to continue the CPR for the next 2 minutes, followed by check the rhythm. So this is the correct answer. So, but let us see the other options. Immediate synchronized cardioversion. Generally, synchronized cardioversion is done for narrow QRS complexes. Narrow QRS complexes. Okay. So this is VT. This is not a case of, narrow QRS complex, wide QRS complex, right? So synchronized cardioversion is generally used in narrow QRS complex. Defibrillate. Yes, this is the right answer. Check the rhythm. No. The moment you give the defibrillation shock, don't wait for the rhythm. Check for the rhythm. You continue CPR. Okay. So this is not the correct answer. Stop CPR. Never. The moment you see it, the moment you look at the question, you did not read the further option also. Stop CPR and do cardioversion. No, this is also a wrong answer. So what is the correct answer? Defibrillate followed by CPR for 2 minutes and check the rhythm. So if at all they have given this ECG rhythm in your examination hall, the correct answer will be a B option, where defibrillation followed by CPR followed by check the rhythm. CPR to be done for 2 minutes. So these are all the questions that have been asked in session 1. Right? Now, let us see the questions that have been asked in session 2. Right? So what are the questions that have been asked? Which of the following is true about this position? So the only person in this entire medical fraternity who likes to align all these 3 axes into one line is the anesthetist, or the person who manages the airway. Why? Because this is the ideal position for intubation. When we can align these 3 axes, the oral axis, the pharyngeal axis and laryngeal axis into one line, then only you can visualize the glottic opening. So what we do in an intubation is generally we try to keep the pillow. The moment we keep a pillow or a head ring, these 2 axes, pharyngeal and laryngeal axis, they get into slight alignment. Okay. The pillow, once you keep, they too get into the alignment. And the moment you extend the neck, this oral axis will get into this alignment. This is called 3-axis model, which we have discussed in the video modules. Okay, where these three axes will come into alignment. And once it comes into alignment, you push the tongue to one side, you can easily visualize. So this is called as sniffing of morning air. Sniffing of morning. There are fancy names here when we are doing intubation. What do you mean by the sniffing of morning air? You might have seen in many movies, a heroine will be there. She goes to a village, early morning she gets up, she opens up the window pane like this. She does like this, right? Sniffing of morning air. Do you remember? Many movies, Indian movies, it shows the same thing. Sniffing of morning air, where we are extending the neck, right? So this is called sniffing of morning air. Most students, they get confused. Not the students who have watched the video, but most students, they think this position, what we use is called rose position. No, rose position is not used for intubation. In rose position, we keep the pillows in between your scapula blades. It is here, see here very clearly, the pillow is in below the occiput and they have given the names also. So what is the correct answer? Sniffing position for intubation. There is other name also, that's like drinking of pint beer or barking dog position. All these fancy names are there. So what is the correct answer? Sniffing of position for intubation. Ideal position for neurosurgery. No, it's not an ideal position. Generally, in neurosurgery, if it is a posterior fossa, there is nothing like ideal. What is ideal? Ideal like, ideal husband, ideal wife, ideal boyfriend, ideal girlfriend, they are not available. In neurosurgery, depending on the surgery, right? There is nothing like ideal. For example, if you are doing this posterior fossa surgery, the position that is very good is sitting position, but it causes a risk of venous air embolism. So we put the patient in prone position. If it is in the anterior portion, we put it in a normal straight position. We put it on the tongs and we put it. So this is not an ideal position for neurosurgery. Ideal position for bougie insertion. Bougie insertion, no. Bougie also, if at all, this three axes, if we can't align for some reason, and you see the glottic opening is somewhere above, bougie will help me in directing, but it is not ideal position, right? It is not an ideal position for bougie insertion. Neck position for intubation. Neck position for intubation. Again, I am neck position. I don't know whether this is the correct answer or not. Neck position for intubation. Head and neck position where, I don't know if it is this for intubation, something, yeah, but neck position. I am not concerned more about the neck position also, but the correct answer will be a sniffing position, right? I don't know whether this option is given properly or not in that examination hall. I don't think they will have given these two options at a time, right? So in neck position, if I want to tell what is this, there is flexion at lower cervical spine, lower C-spine, extension at atlanto-occipital joint. Okay, so at lower cervical spine, that is here there is a flexion and extension at atlanto-occipital joint. So what is the correct answer? I don't know whether the options are right or not, but I will choose for sniffing position for intubation. Sniffing of morning air. Okay, let us see the next question. Which of the procedure is being done in this image? Again, this is a classic image which I have showed you in the same image. I have put it from the video session only. So where we have tied the tourniquet, inflated the tourniquet and kept an IV cannula here. So this is a classic case of Byers block. I showed the video of, I showed the images. How are we doing this axillary block? The name itself is saying axillary block means we are putting the injection in the axilla. Here, we palpate the axillary artery and we will put the injection. Here in this, we have tied the BP cuff. Only on the side where we are doing the surgery. Surgeons are interested in tourniquet because they won't want that side to be bleeding. And the anesthetist is interested in tourniquet only at Byers block. Okay. Median nerve block, no. Median nerve block, it can be approached here at the wrist joint in between your palmaris longus and flexor carpi radialis. Here, this middle portion, if you can see it clearly, this middle portion is a median nerve block, right? Here somewhere we are not doing anything. Wrist block. Wrist block means again, this is not one block. Wrist block means here we are putting this ulnar nerve. Here is your median nerve. And you can put this injection in this snuff box with the radial nerve. So this is not even the wrist block. The answer is very clear. This is a case of Byers block. So Byers block, the advantage is, the other name of Byers block is IVRA, intravenous regional anesthesia, right? Intravenous regional anesthesia, because we are injecting the anesthetic through the intravenous route after tying the tourniquet, right? So after 5 minutes, you can see the whole hand become numb. What is the advantage of buyer's block is it is a very simple and effective procedure. You need not know the anatomy. If you can put a IV cannula, you can give a buyer's block, right? So what are the drugs that are approved? Drugs approved is lignocaine, 0.5%. Prilocaine can also be considered, but in our country, prilocaine is not available. So what is the correct answer? Lignocaine, 0.5%. Drugs that are contraindicated. Drugs that are contraindicated is bupivacaine. Why bupivacaine is contraindicated means, suppose during the surgical procedure, if this tourniquet become loose and accidentally, entire bupivacaine will go into the patient's heart and it causes cardiotoxicity. So first patient dies because bupivacaine induced arrhythmias are very difficult to treat. And this question was asked many times. What is the treatment of bupivacaine induced arrhythmias? It is 20% intralipid. 2 times in the last 3 years this question was asked. So bupivacaine we don't use it because once the tourniquet loses, it goes into your systemic circulation and cause cardiac toxicity. So first patient dies. By looking at the death of the patient, surgeon dies. He will get ventricular fibrillation and he will die. Both of them are dying. So I will also die because no one will feed me. Right? So why to kill 3 people? So we will stop using bupivacaine. So generally we use lignocaine. Now you might get it out. Sir, if I use lignocaine, if the tourniquet loosened there, it will cause seizures. Yes. It will cause seizures. Seizures I can manage because seizures, I have a lot of drugs in my armamentarium like midazolam, thiopentone sodium, etc., which you can give and control the seizure. Seizures can be controlled. Lignocaine-induced seizures can be easily controlled. But bupivacaine-induced arrhythmias, I said you, patient will die, surgeon will die, and I will also die. Okay. So what is the correct answer here? The correct answer is buyer's block. Right? Now let us see the next question. A patient is undergoing implant surgery for his upper limb. On giving general anesthesia, he develops tachycardia, sudden rise in body temperature and rigidity of the muscles. The moment they said rigidity of the muscles, this is a case of malignant hyperthermia. And what is the drug that is most likely to cause it? This I have told it. I have made a separate session of 20 minutes on malignant hyperthermia. Right? The malignant hyperthermia, the most common implicative drug is all inhalational agents. All inhalational agents and succinylcholine. So let us see the options. Halothane is an inhalational agent, right? Nitrous oxide is not an inhalational agent. Nitrous oxide is a gas. It doesn't trigger malignant hyperthermia. The second option is etomidate is an intravenous anesthetic. So it is also doesn't trigger. Propofol is a safer option. It is also doesn't trigger the malignant hyperthermia. So what is the correct answer here? The correct answer is halothane. Right? Now, I said you many times, those who are doing the revision by looking at these questions, let us quickly I'll tell you some of the clinical scenarios. You can easily come to a diagnosis because this is a recall session. They might have asked something else. So what is the first clinical presentation? I'll make it like a tabular column so that you will understand. The clinical presentation, the first one is sudden tachycardia, hypertension, increased body temperature, increased EtCO2. Hey doc, can you make the diagnosis? 60 seconds, right? Very popular on the social media, right? Increased EtCO2. The answer is malignant hyperthermia. Second scenario, sudden tachycardia, hypertension, shark fin pattern of EtCO2, increased airway resistance. This is a case of bronchospasm. Right? Sudden tachycardia, stridor, rapid desaturation. This is a case of laryngospasm. Right? Next one, sudden tachycardia, hypotension, increased airway resistance, and edema. Airway edema, facial edema, pink color, the face has swollen. This is a case of anaphylaxis. These are common scenarios in our practice. In anesthesia, these are some of the clinical presentations where you can encounter all these clinical presentations, and this is very, very important. I was expecting this. I told a detailed lecture in pre-anesthesia checkup about all the various presentations that can happen. Okay, so this has been straightforward answer for you. That is halothane. Right? Now let us see the next question. At what pressure does the structure that is marked open? Right? I think this they wanted to show this. Okay, so this is something which every student, every intern might have used it. That is called ambu bag. Okay, you call it as ambu bag, but ambu is a company name. I said in that video. Ambu, instead of ambu, we use a word that is called self-inflating manual resuscitators. Self-inflating annual resuscitators. Next time when you see any equipment in the hospital, please watch it carefully. The routinely used equipment. This is a classic example of it. This marked portion is called as pop-off valve. Pop-off valve. Or pressure relief valve. Pressure relief valve. Okay. So when you press this bag, squeeze this bag, the gases will flow. There will be unidirectional valves will be there. The gases will flow to the patient. Okay. But there is a chance that they can cause barotrauma. So especially in pediatric ambu bags, next time when you see it, you can see it classically a pop-off valve will be there. And this pop-off valve, any valve measurements, any pressure measurements, they do it in centimeters of water. So out of which you can easily rule out two options, millimeters of mercury, right? The main purpose of pop-off valve is to prevent barotrauma, I said, prevent barotrauma. So normally at what pressure you are breathing? So think like a normal person. I said you that is slightly difficult, but if you practice, it is not a very impossible task. So at normally what we are breathing right now in this room is negative inspiration. So we are breathing at a pressure of -5 to -8 centimeters. Normally we breathe at -5 to -8 centimeters. This is -5 to -8 negative intrapleural pressure that is developed. So that's the reason why I get inspiration. My exhalation, the pressure will be 0 because due to elastic recoil. So exhalation will not cause any positive pressure. It will bring back to 0. This I taught you in the section of mechanical ventilation, normal physiology of the lungs. This is not happens normally. But when I am squeezing this bag, this will become positive pressure ventilation. When I am giving positive pressure ventilation, that means completely ulta, right? Completely opposite what we are doing normally, right? So what happens here? Positive pressure is developed. Now there is a chance, if you give lot of positive pressure, there might be chances of barotrauma. So normally when I put you on intubation and give the squeeze pressure, generally we give it around 10 to 20 centimeters of water. For a normal lungs, the pressure that is generated in your airways will be 10 to 20 centimeters of water. I should be very careful. If I exceed the pressure, there can be chances of barotrauma. So 10 to 20 is a normal. So 10 to 20 centimeters is a normal. He said when this valve will open. It is opening means it is avoiding barotrauma. So at 10 to 20 centimeters, if it opens, then it will not help you in giving positive pressure ventilation. So I have ruled out 3 options for you. Then what is left over? 30 to 40 centimeters of water, right? This is written on most of the companies' ambu bags. Ambu is a company name, I said you, right? That's the reason why some hospitals have LARDL, some hospitals have some other ambu manual resuscitators. Most of the companies, they give this value on this reading. Next time when you go to any hospital or if you happen to see any ambu bag, most of the companies, I said it's not mandatory to write, but most of the companies, they mark it as 30 to 40 centimeters, that too especially in pediatric, because pediatrics lungs are very, very thin and fragile. So there can be chances of barotrauma. In adult, sometimes this pop-off valve can open up to at 60 centimeters of water. 60 centimeters of water. I agree this. I have not said how much pressure it will open, because, I said that there is a valve. In my video session, I said that there is a valve. But yes, this is how the questions are framing in your examination. Following is the image of a normal capnograph. What is the true about the segment C to D? Right? What is the true statement about the C to D? Following is the image of a normal capnograph. What is the true statement about C to D? Now, we have discussed this many times in our video sections, many times in the revision modules also. So, this is a normal capnograph, right? Capnograph, how it is formed? Capnography means it is measurement of, or a graphical representation of exhaled carbon dioxide. Exhaled carbon dioxide, right? Now, how we are exhaling carbon dioxide? Inspiration. When I exhale, the first gas that is coming out from my body is the gas that is present in the dead space. So, there are 4 phases in the capnograph. This is called phase 1, this is called phase 2, this is called phase 3, and this is called phase 0 or phase 4. Some people call it as phase 0, phase 4. So, the first portion, the gases are coming from the dead space. Dead space gas doesn't contain carbon dioxide because it has not mixed with a gaseous exchange. So, it is always touching the baseline. The moment the dead space gas goes out, upper alveoli will start exhaling. This is called expiratory upstroke. This is called expiratory upstroke. This portion corresponds to the expiratory upstroke. Once the upper alveoli is emptied, all of the gases that are coming, they are coming from this phase 3. This is called alveolar plateau phase. What do you mean by plateau? Plateau means a straight line, but here it is not a straight line. The reason being is the gases come out quickly from middle and lower alveoli. Middle and lower alveoli. So what happens is there is unequal sizes of middle and lower alveoli. That is the reason why you can see a slight upstroking. Then once the gases have reached to that lower alveoli, at this point we measure the exhaled carbon dioxide or EtCO2. We measure this. All gases have went out. This is called inspiratory downstroke. Downstroke. Right? So how is this curve looking like? If you put a curve like this, now can you see here how it is looking like? I'll remove this one. Now you can understand, right? How it is looking like? Right? How it is looking like? It is looking like a top hat shape, right? So this is a normal capnographic curve, a straightforward question that has been asked, which we have discussed it. So what is the correct answer? C to D represents the alveolar gas and a plateau phase. So inhalation of fresh gas, that means D to E. Exhalation of dead space air, that means A to B. Exhalation of mixed gases. I don't know whether they have given the exhalation of mixed gases or not, but the correct answer is a plateau phase. This is also not the correct answer because this is a recall session, right? So we don't recall the options properly, but the correct answer is a plateau phase, right? Now shall we see the next question? This recovery position is appropriate for. This is a repeat question which was asked in NEET-PG 2023. The patient is kept in left lateral position. When do you like to keep a patient in left lateral position? This we have discussed in the chapter of basic life support. When a patient is unresponsive, right? So responsive option is gone, obviously, right? So unresponsive, pulse and breathing is present. If the pulse and breathing is absent, you will start CPR. Pulse is absent means dictum, start CPR. Breathing is absent, unresponsive patient with pulse but without breathing. Why are you putting the patient in left lateral position? You have to give rescue breaths. Rescue breaths. How many rescue breaths you have to give? In the basic life support, I have said you 1 breath for every 6 seconds. With the help of ambu bag, 1 breath for every 6 seconds. So, whenever a patient is having pulse and breathing but he is not responsive, put the patient in left lateral position. Not only this pulse without breathing or gasping also. Gasping also, we will put the patient in, we will give the rescue breath. But if the pulse and breathing is normal, the same question was asked in NEET-PG 2023. So, what is the correct answer? Unresponsive patient with pulse and breathing present. Right. So, these are the questions that have been asked in your entrance examination. I hope most of the students, they have answered these questions, and most of the things what we have discussed in the videos and the revision session, they have came in your examination. So, with this, I sincerely pray to the God that whatever the seats you decide, you get it. Those who have written the examination, congratulations. Those who are preparing, all the very best. Don't take it negatively, because this is one experience which you are getting. Lot of things happened during this examination. Getting this examination was very tough for you, right? So from this, prepare yourself. Those who are preparing, make up your mind, identify your mistakes where you are going wrong, and try to improvise yourself, right? So with this, I conclude the session of NEET-PG 2024 recall session. Thank you all. All the very best for the future.